respected guests, Assalamu alaikum, and a very good evening to you all. Welcome to the Radiology Session of Pre-Conference Workshop 2025, organized by the Bangladesh Society for Breast Cancer Study. It is my immense pleasure to be the moderator of this session. I am Dr. Rubama Karim, working as Junior Consultant, Department of Radiation Oncology, Ahsania Mission Cancer and General Hospital. I'm truly honored to guide you through the discussions we'll have today. We have an esteemed panel of experts with us today whose insights will undoubtedly enhance our understanding of key topics in breast cancer care. Our distinguished panelists are Professor Dr. Sharmin Akhtar Rupa Ma'am, Consultant, Radiology and Imaging, Bangladesh Specialized Hospital. Professor Brigadier General Retired Jahangir Alam Sir, Radiologist, Square Hospitals Limited. We are honored to have Professor Brigadier General S.M. A. Al Muid, Retired, Professor, Department of Radiology, Bangladesh Specialized Hospital. Throughout the course of this session, we'll be hearing insightful presentation from Dr. Rashmi Chand. I'm confident that we are in for a truly enriching session. Without further ado, please join me in welcoming Dr. Rashmi Chand to begin with the session.
So my session is in 3 parts. I'm going to teach you breast MR. So the first part will be how to report a normal MR. Second, what happened? Part of the MR will be how do you report in breast MR post neoadjuvant chemotherapy, and something very exciting that we do back in India, abbreviated MR, which is something new. So I want to teach that also. So without further ado, let us start. So as you know that the 3 parts, 3 topics, breast MRI, post neoadjuvant and abbreviated breast MR. So when we are coming to breast MR, what am I going to speak on? So first thing, what are the indications for breast MR? How am I going to do the breast MR? How do I interpret an image? How do I come to the BI-RADS? And what are the common findings? I've got 10 cases for discussion over here today. So what are the indications? So the first thing is the high-risk screening. The high-risk screening, especially the BRCA mutation or relatives of BRCA mutations or certain syndromes. So these are the patients who you will start screening by breast MR from the early age of 30 to 35 years. Second, you have diagnosed a cancer in ultrasound or in mammography. Then why you need to go for an MRI? You want to know the extent of the disease. You want to know if the rest of the other breast is involved. You want to know what happens to the disease after you have given neoadjuvant. You also look for metastatic disease, which has got an unknown primary on mammography. So basically, MRI comes as a problem-solving tool, especially if you have a suspicious nipple discharge, and especially females who have a silicone implant. So how do you do an breast MRI? So you have a dedicated breast MRI coil, and a post-contrast study is very necessary, and it can be done in a 1.5 or a 3 Tesla MR. Now what is important to remember is if you are doing a breast MR, you should have MRI guided interventions, or you should be associated with a center which has MRI guided interventions. Otherwise it's of no use doing the breast MR, just picking up and you don't know where to do the intervention. So this is how the patient is put. The patient is put in a prone position. So here the head is, both the hands are in the front, and the coil. This coil that you see is the breast MR coil, and these are the images that will come over here in the breast MR. So what are the key sequences that you take? So firstly, the T2 sequence and the T2 FAT-SAT or the SPIR or the STIR. P-contrast T1 sequence. So T1, 2 types of T1. One is a normal T1, second is a T1 FAT-SAT. Then you do the dynamic contrast. You give contrast and you do an early phase dynamic and a second phase dynamic. And I'm going to explain to you all the sequences. So when you do a breast MR, how do you read the images? So the first image that you should look at is the T1 image. and then you should jump to the contrast. Why? Because even in T1 and T2, you won't be able to pick up. It's until something is enhancing, then you retrospectively go back and start looking at T1 and T2. So what I recommend is look at the T1 and then go back to the contrast images, and then the rest of the sequences will follow, like subtraction, MIP, T2, the sagittal and the coronal images, kinetics, and some special sequences. I'm going to explain to you. So this is how the whole image layout looks. So you have a T1 fat sat, you have a post-contrast T1, you have a non-fat sat T1, you have subtraction images, then you have the MIP, where you see all the vessels, the sagittal and the coronal, and the fluid sensitive, that is the stir or the spare sequence. Now, why I want to do a normal T1 sequences? Because there are three things which are bright on MR. What is it? Fat, blood, and melanin. So if you have a lipoma, you're going to miss it. So you want to do a T1 non-fat sat sequence to look for lipomatous lesions and to look for susceptibility artifacts. Now, why am I doing a T1 fat sat? So if you're saturating the fat, the rest thing that becomes bright are only two things, blood and protein. So over here you can see that somebody has done a biopsy and caused a hematoma which looks like a mass. So you have done a T1 post-contrast, you have got bright images, so this is a post-contrast hematoma. So this is why you want to do a T1 fat sat sequence. Now why the T2 sequence? So the dictum goes that everything that is black on T2 is supposed to be cancer. Okay? And what are the anomalies? There are very few anomalies. One of them is a cyst, the second is a fibroadenoma, and one of the cancers is a mucinous carcinoma, which looks bright. So everything that is dark on T2 is suspicious. Now fluid sensitive, you want to pick a fluid and cyst, so you're doing the T2 fat sat or the stir or the spare sequences. Now, what is a subtraction sequence? So what you do is you do the normal post-contrast and you subtract it from the normal breast, and then over here you will get a subtraction sequence. So what happens in a subtraction sequence is that something which is enhancing and you have suppressed the background, you can see that very clearly. So you do the subtraction sequences. So these sequences are actually done by your computer. You are not doing it. You have taken the post-contrast and then your computer is running all these sequences. Then you do something known as MIP. So in MIP, what happens, you see all the vessels, and you know the surgeons love the sequence. Sir can confirm over here. So they can see the sequence, they can see the lesion, and they will understand the correlation with the vessels. So the surgeons love the MIP sequences. Now, you have found out a lesion. What are you going to do? So you're going to look for that particular mass lesion, not only in the axial scan, you will see the sagittal, the coronal, you will see all how that lesion looks in all the sequences, and you will also correlate with the mammography and the ultrasound if you have them. So how are you going to tell where the lesion is in the breast? So mind you, like ultrasound, we do not give clock in MRI. We just give the quadrant. So suppose this is the right breast. So whatever is towards the chest wall is the medial. Whatever is towards the axilla is the lateral. So you come to the sagittal. Whatever is going towards the axilla is superior. So whatever is coming down is inferior. So if there is a lesion here and here, so you will know that it is in the superomedial quadrant. So that's how you're going to tell where the lesion is. The same thing for coronal. Whatever is towards the chest wall is medial. Whatever aware is the lateral. Now, we have done a post-contrast study. Now, what are the things that you're going to write in a post-contrast study? So the first thing that you're going to write is, what is the background parenchymal enhancement? Have you picked up a lesion? What are the associated findings? You're going to look at the lymph nodes and any other extramammary findings. Also, what is important is you're going to review the patient's history. Why did the patient come for? She fell for a lump. There was a discharge, and after you have evaluated everything, you will come to the BI-RADS and you will give that lesion a BI-RADS. So, how are you going to give the lesion a BI-RADS? So, there are a lot of things which are going to help you determine the BI-RADS. So, the first thing that's going to come is the breast density, then the background enhancement, then you're going to describe the morphology of the lesion, then the kinetics and the other findings. So, I'm going to describe all of this in details. Now, first thing that you're going to report over here is how much percentage of fibroglandular tissue is there. So this breast that you see is entirely fatty, 25% of fibroglandular fat, so this is scattered fibroglandular density, heterogeneous, around 25 to 50% of fibroglands, so this is heterogeneous, extreme, more than 75%. So the first thing that you want to write is the amount of fibroglandular fat that is present in the breast. You have given the contrast, and then you're going to write about what is the background parenchymal enhancement. So what happens is when you give contrast to a breast, the lesion will also enhance and the breast will also enhance. And it is seen that during the luteal phase, the enhancement of the breast is the most. So what we tell is that please do not get your breast MR findings from between 7 to 14 days, or you do it after don't do it after the 14 days, the ovulatory phase, because normally the breast is very dense that time and the enhancement is a lot. So if you want to schedule an MR, it's not urgent, you schedule it between 7 to 14 days. This is mild, around 25% of the breast is enhanced. This is moderate, 25 to 50, marked enhancement. So this is the first thing that you're going to write in the report, post-contrast enhancement. Now this is very important, is that both the breast should be enhancing simultaneously and it should be symmetric. Now here I give you a case where one of the breast is enhancing, the second breast is not enhancing. Why? Because this was a breast which was reconstructed, had got radiation. So this is asymmetric breast enhancement. So you're going to write whether it is a symmetric enhancement or an asymmetric breast enhancement. And after this, we come to the BI-RADS lexicon and what are the common findings. So if you pick up a mass, so there are three things that you're going to pick up: a focus, a mass, or a non-mass enhancement. So what is a focus? You have given a contrast, and there is a very small dot-like enhancement. So when you see this dot-like enhancement and the size is less than 5 mm, you're going to tell that this is a focus, okay? So if that focus on T2 is also bright, then it is benign. If that focus on T2 is not bright, you are supposed to biopsy that focus, okay? So why you're going to biopsy? Though the percentage of malignancy is less than 3%, but still you will give that patient and you're going to biopsy it. So this is about focus. Now, second thing that you're going to see is a mass. So when you see a mass, you're going to tell about the shape, the margin, how it is enhancing, and what is the kinetics. Now, what do I mean by mass? What is the shape? So the short form for shape that we use is ROI. It's not return of investment. It's round, oval, and irregular. So come over here. So this is a round shape. This is oval. And this is irregular. So lot of us use those terms, microlobulated, lobulated. Don't use those terms. There are only three things over here: round, oval, microlobulated. Now you will have a lesion which is round and some part of it will be microlobulated. What are you going to write? You're going to write the characteristic which is the verse. Are you getting it? So you're going to give that as irregular. Okay? Get that in your mind. Homogeneous, the whole of the lesion has enhanced beautifully. Heterogeneous, certain non-enhancing areas are present in that mass lesion. Rim enhancement, that is, the border of the lesions has enhanced. So these are the three kind of enhancements that you are going to get in a mass lesion. Now this is something very specific. You have given contrast, the lesion has enhanced, and in the lesion, can you appreciate these dark T2 septations? So these dark T2 septations have not enhanced, and this is very characteristic of a fibroadenoma. So dark internal septations which do not enhance is fibroadenoma. So we have picked up focus, we have picked up mass. Now there is something known as non-mass enhancement. You have given contrast, and you just see enhancement. But this does not conform to a shape. So what are you going to call this? So this is non-mass enhancement. Now what are the types of non-mass enhancement? So as you see over here, this is linear. Why? Because this is a straight line. So this is ductal enhancement, and you have 61% of malignancy in that. If you see a few clusters and dots, so this is known as focal enhancement. This has got 25% malignancy. Now you see over here a segment is enhanced. So this is known as segmental non-mass enhancement, and you have around 78% of chance in cancer in this. Then you have more than 3/4 of the breast enhancing. So this is regional non-mass enhancement, and you have 21% chance of breast cancer in this kind of a mass. Now, even in non-mass enhancement, it has got a certain kind of a enhancement pattern. If the whole of the non-mass enhancement is homogeneous, you call that homogeneous. If you have some non-enhancing areas, it is heterogeneous. Clumped, some clusters of enhancement. So this is cluster type of non-mass enhancement, and clustered rings. So you can see peripheral enhancement. So this is clustered ring type of non-mass enhancement. Now, one of the most important things that we do in a breast MRI is we give contrast. Now, how much contrast? 0.1 millimole, use a power injector. What is the flow rate? 2 ml per second. After you give contrast, you give a saline bolus of 20 ml, and that is how you do a dynamic contrast. So, why do we use the word dynamic? Because it is taking repeated images, and in our software, it is taking 4 sets of images, okay? 4 sets of axial images. So, the first image is something around 1 minute, second image around 2 minutes, third at 4 minutes, and the fourth one at 5 minutes. So you will get total 4 sets of images in a dynamic MR. And what you're going to do is, suppose you have picked up a lesion, you will draw a circle in that enhancing part, and that is known as an ROI. And that how much ROI are you going to give? Such a big ROI, so it all falls over there. So you get this over here. So this is the 4 sets of images. Enhancing, you have put an ROI, and then you have got a curve. Now what is this curve? So on the x-axis you have the time, on the y-axis you have the signal intensity. So can you draw ROI only of one lesion? Over here you can see that multiple ROIs you have. So in one image, if you have 5-6 lesions, you put one ROI in the normal breast, and then you put ROI in all the lesions that are enhancing. So this is red over here. So this is the line for the normal breast, and these are for the other 3 lesions. So I'm going to describe you what this time intensity curve means. So time intensity curve, there are 2 parts to this curve. So the first part is the 2-minute curve, and the second part is what happens after 2 minutes. So in the 2 minutes, there are 3 things that will happen. Either the lesion will enhance slowly, or it will have a medium enhancement, or it will have a very fast enhancement. Now you are asking me that why do we have these 2 parts of a curve, first 2 minutes and then 2 to 6 minutes? So the reason over here is that it has been seen that lesions which are enhancing very fast in the first 2 minutes correlates with a very high tumor grade and Ki-67. So the proliferative index of these tumors are very high, and you're going to say that this is actually a very bad tumor. So that's why you're going to make the curve. So the first description will be what happens to the tumor in the first 2 minutes, and second description will be what happens to the tumor after 2 minutes. So now what happens to the tumor after 2 minutes? There are 3 things that can happen. Either the intensity will keep on increasing, so that you will know as a persistent type curve, or it will become a plateau, it will just same signal intensity, no change, that will be a type 2 curve, or it will just come down, wash out, so that will be a type 3 curve. So what is the significance of these 3 kinds of curve? So when you have a progressive or the type 1 curve, it's going on increasing. So mostly you see 83% of these lesions are benign. So when you get a type 1 curve, sort of you're reassured that this is kind of a benign lesion which I'm looking at. Type 2 curve, where the signal intensity rises and then it becomes a plateau. It's not rising anymore. So here what it is, the sensitivity of malignancy is only 42.6 and the specificity is only 75. So you don't know where it's going. It's benign or malignant. You don't know. You have to look at the morphology now. Type 3 curve, rapid enhancement, rapid fall. So this is very much particular for a malignant lesion. So the specificity is 90.4, sensitivity 20.5. So a type 3 curve more or less points towards malignancy. Okay? So I'm giving you examples of fibroadenoma, benign lesion, rises over here, persistent, type 1 curve. You have a lesion, rapid wash-in, and then a washout. Type 3 curve. So this is a malignant lesion. You have a lesion which has got initial uptake, then has become a plateau, somewhere hanging in between benign and malignant. So after you have described the mass lesion, you have described how it is enhancing, time to look at the other features. What are the other features? Nipple retraction present or not? Nipple invasion present? What is about the chest wall, the axillary lymph nodes, and the pectoralis muscles? So here I give you a case where you have a non-mass enhancement. The nipple is involved, the skin is thickened, the fat plane with the chest wall is lost. So it has invaded the chest wall. So you don't only look at the lesion, you look at the associated findings also. So we have said about the lesions. Now what about the lymph nodes? So the axillary lymph nodes, you label them into 3 stations. Type 1, that is it is in the level 1 axillary, level 2 and level 3. Now whenever it comes for axillary lymph nodes, I prefer the coronal sections. Now why? So this that you see over here is the pectoralis major muscle. This which you see over here is the pectoralis minor muscles, and whatever around over here are the lymph nodes. So what are the level 1 lymph nodes? So which are lateral to the lower body of the pectoralis and lateral to that. Level 2 nodes which are deep to the pectoralis muscles. Level 3 which are medial. So you are not just going to write that axillary nodes involved. You're going to give the level 1, 2 and 3. And you also have the interpectoral nodes, that is the rotor nodes between the major and the minor. Got it? So you've got the lesion and you've got the nodes. Now, if the person has got a breast MRI implant, so there are a lot of other things or other lexicons that come. What is the kind of implant? Saline, silicone. What is the location of implant? What is the contour? Whether there's rupture or not? Is there extracapsular or intracapsular rupture? So I've not gotten details for this, just given one image of an intracapsular rupture, which you know as the Lingwin sign. So you have got a mass, you know about the lymph nodes, now you're going to put it in BIRADS. So what you know is that BIRADS 0, it means you need to do something else. 1, normal breast. 2, benign. 3, you want to follow up. 4, 5, you're going to biopsy. Now what is important is in MRI BIRADS 2, what are the things that you will safely say I'm not going to biopsy? This is absolute benign. So the things which are absolute benign are intramammary lymph node, implants, metallic foreign objects, enhancing and non-enhancing fibroadenomas. Now this fibroadenomas, some people put it as BIRADS 2, some people want to follow it up as BIRADS 3, but MRI BIRADS says that fibroadenoma is BIRADS 2. Cyst, non-enhancing scars, post-operative collection, fat-containing lesions. So all this is BIRADS 2 and you're not going to biopsy them. So this is how we make our report back in our hospital. So we write the technique, we give you the history, and then we write about the findings. So the first thing I told you, how much of glandular parenchyma. Second thing, you give in contrast, what is the background enhancement. Then you're going to say whether you've picked up a mass or not. Then you're going to write about what about is about the skin and subcutaneous, the chest wall, and the lymph nodes. Yeah, sure.
Thank you. We also have a parallel session on pathology on the other side. Those who are interested, you can join the other side. Thank you. You can start.
Thank you. So this is how we make a normal MRI report at a center. So I have brought a couple of cases over here. So if it could be interactive, I'd really like it. So we'll start with 10 cases and very simple. So the first case. 44-year-old comes for breast MRI screening. What do you see? T2, simple cyst. T1 fat sat, not enhancing. Subtraction, not enhancing. How many of you say this is benign? Put up your hands. Very good. How many of you say this is malignant? None. So I think I've been teaching right. So this is a T2 bright lesion, not enhancing. So this is a BIRADS 2. Are you going to biopsy this? No. Very good. Second case, T2 bright. Contrast mein, what happened in the contrast? There is peripheral enhancement. Is there diffusion restriction? Yes or no? No. No, no, no. I don't know about the image, so it's no, because in ADC it's not black. Okay? So what is the BI-RADS? Benign or malignant? Benign or malignant? Benign? Yes. But what is special about this? The peripheral enhancement. So this is an inflamed cyst. First you saw a simple cyst, now I showed you a inflamed cyst. Third case, 42-year female felt a lump in the left breast. So T2, you have a lesion. You can say round, circumscribed or non-circumscribed? Okay, circumscribed. We have given contrast. What kind of enhancement? Peripheral and septations have enhanced or not? They have enhanced. Very good. Diffusion restriction, little bit in the partial part. So, what do you give the BI-RADS? Now in this, you have diffusion restriction, you have peripheral enhancement. So let us put it, cancer, not cancer? Not cancer? So it's cancer, it's IDC, because there is peripheral enhancement over there. The septation is enhancing. So this is what I want to tell you. So you see a T2 bright lesion which shows diffusion restriction, complete restriction, abscess. If you show partial diffusion restriction, tumor. Got it? Fourth case. So first tell me, is it circumscribed or non-circumscribed? Non-circumscribed. Diffusion? No. Yes or no? No. What do you see in contrast enhancement? So there is kind of not much enhancement and the curve is kind of a plateau. Okay? What BI-RADS want to give? Something over here I'm showing you. I told you. What is this? 2. Why? The dark internal septations. I told you no? Fibroadenoma. So this is not enhancing. So this is a fibroadenoma. So the take home message over here, if you have a septa that does not enhance, is fibroadenoma. If you have a septa that enhances, is cancer. Got it? Now this is coming to this case, fifth case, very important. You have a T2 lesion. How does it look? Kind of an ISO. No, not very distinct. T1 dark. Diffusion? No diffusion. And you have started given the dynamic and it's kind of showing a homogeneous enhancement. So what do you feel about this kind of homogeneous enhancement? Cancer, non-cancer? Straight thing. How many for cancer? Okay. Now there's something which I want to tell you. So whenever you pick up a lesion, you have a switch in your computer which says enlarge. Okay. Now I enlarged it. Now tell me, is this circumscribed or not circumscribed? Not circumscribed, lobulated. So always enlarge your images. Got this? So over here, so this is kind of a microlobulated margin. And I want to show you over here. So T2 non-enhancing and you see the fluid in between. So this is known as fluid cleft sign and this is important for a phylloids tumor. Now you need to differentiate between phylloids and fibroadenoma. Fibroadenoma, when you'll operate, you'll just operate that small region. Phylloids, you have to take out a bigger chunk. So fluid cleft sign is very important. So this is my sixth case. T2, lesion is there. Now there's something very special about this lesion. You see over here, it's got a T2 rim. You can see the rim over here. No, kind of a diffusion restriction. And as you said, there are two sets of images that we take early and then one after two, enhancing. We took the delayed. What happened? The rim is enhancing more than the tumor. Are you seeing that? And you've drawn the MIP images. So what is the BI-RADS? Cancer, non-cancer? Cancer. Very good. Now what is the kind of cancer are we looking at? So you have a T2 fibrous rim and what you see over here, you know, these kind of extensions that are going, so that is kind of a lymphoplastic response. And the capsule is enhancing in the delayed phase. So this is very specific of medullary carcinomas. Okay, got it? Seventh case. So this is a lady who was diagnosed as a benign duct papilloma, but the surgeon was not happy, so we went for an MR. So T2, you got something hyperintense, T1 hypo, no diffusion restriction. First phase, you see capsular. Second, delayed, you start these enhancing nodules and you see the prominent vessel which is going there. So what is this? Cancer, non-cancer? Very good. So this is what? So you have nodular papillary projections and something else which you all didn't pick up. What is this over here? This is, what is this? Segmental non-mass enhancement. I told you about that now. Not the lesion is enhancing and you have segmental non-mass enhancement. You have engorged internal mammary artery. So this was intracystic papillary carcinoma with extensive papillomatosis. Okay. Oh, this is a very interesting case. So you see over here T2 full dark. Oh, you want? This is not pointing? Okay, sorry. Okay. So this is very interesting. So you have a T2. Now told about the asymmetry part. Okay, wait. So the pointer is not going up to there. Okay, here. You can see the asymmetry part over here. So over here you have a lot of T2 and lot of breast is involved. Here not that much. We did have a diffusion restriction. We got diffusion restriction. We did contrast. This is enhancing. Now, what was peculiar is, this is a lesion, such a big lesion, no skin thickening, not going to the nipple, no lymph nodes. Now, what the hell is this? Can you tell me what kind of a lesion will be there in the breast where you will have such a big lesion and you will have no associate findings? Tell me, what are the answers? There's no desmoplastic reaction. We have something known as a penetrating vessel sign. And what was this? This was a B-cell lymphoma. Again, one more case. You can see in mammography, there's a speculated lesion. T2, you have a fibrous rim. T1 hypointense. You have done the contrast. There is surrounding enhancement. The septa is also enhancing. So cancer or not cancer? Very good. So I'm just hitting it on the spot then. So this is a primary D-nut tumor, and again you see no associated symptoms. Skin is normal, no nipple retraction, nothing. So I just want to tell you over here, so the tumors from the breast will come from something from the lobule or the milk ducts, and the tumor can also come from the epithelial or the fibrous that is around. So if it's only in the duct, it's known as in situ. When it spreads out, it is invasive. So ductal carcinoma, lobular carcinoma, all these coming from the lobules and the ducts. And what about the other tumors coming from the lymph? Lymphoma, from the vessel, angiogenesis, angiosarcomas. So you have to remember, so everything that you see is not coming from the ducts. There can be tumors coming from the other parts of the breast also. So this is the last case, and this is found in our country simultaneously. So this is a 35-year-old female who's got a discharging sinus, and you see over T1, this is kind of a peripheral enhancement. Then diffusion restriction, there are nodes with discharging sinuses. Is this tumor or infection? Infection, very good. So this is tuberculosis, which we get in our countries very commonly. So keep this in mind. So what have I taught you? What are the T2 hyperintense lesions? Simple cyst, abscess will show diffusion restriction, fibroadenoma, T2, septa, okay, mucinous tumor, you will get kind of a delayed capsular enhancement, medullary carcinoma, T2 fibrous rim, papillary carcinoma, enhancing papilla, and a sarcoma. What are the T2 hypointense? Most of them are cancers, like you have IDC, lymphoma, you will not have any skin or associated findings, sclerosed papilloma, or a mastopathy. So this is how we finished the T2 and the T1 lesions. Okay, so this is normal breast. No, so you ready to report breasts, what happened after chemotherapy? Yes, very good, enthusiastic. So we are going to report breasts, you have given chemotherapy. And the question comes, why do you want to do an MR post-chemotherapy? Two reasons. You do after 2-3 chemo sessions, you want to see whether your chemotherapy is acting or not. You do after 6 sessions and to see what has happened to the tumor and how much am I going to operate or what is the tumor that is left behind. So MRI is one of the best modalities to pick up this. So what are you going to see? You're going to see the size of the tumor, you're going to see whether the volume of the tumor has come down, and also you're going to look for enhancement. And there are 3 things you will say: complete response, partial response, or non-response. But what happens in MR is either it overestimates the lesion or underestimates. So you will be a perfect radiologist if the size of your tumor matches the pathological tumor. And that is your perfectness over there. But that actually doesn't happen in MR. So what are the caveats and why it doesn't happen? I'm going to teach you that. 2 terminologies you have to remember. PCR means complete response. So nothing is there. What is residual cancer burden, RCB? That there are 4 parameters to assess that. You will measure the primary dimension of the tumor, the cellularity, what is the size of the largest nodal mets, and how many number of lymph nodes are present. So when you give neoadjuvant, how the tumor is going to respond, how it's going to shrink. So there are two main importance. There's something known as concentric shrinkage and second is a crumbling. Now what is concentric? You've given a mass, it is enhancing. Around that, there is no non-mass enhancement, okay? You give the contrast and the tumor reduces. So over here you can see this is the pre-treatment, post-treatment, the whole 3D tumor has come down. So this is concentric shrinkage. Pre-treatment, post-treatment, the tumor has come down. This is concentric shrinkage. Now what is non-concentric shrinkage? So the tumor crumbles. The size is the same, some part enhancing, some part non-enhancing. So, and you know, when this kind of tumor comes, it's very difficult to say how much of residual tumor and how much of post-fibrosis. And where do you see this? DCIS or invasive cancers. So here you will overestimate or underestimate the tumor. So here what has happened? Pre-treatment, you can see the tumor nicely enhancing. You've given chemotherapy, like the biscuit, it has crumbled. Some parts are not enhancing, the size is the same. Now what are you going to say to this, whether the chemotherapy has acted or it has not acted? So this is a non-concentric shrinkage of the tumor. Okay? Now this chart, this looks very scary, but you have to know this. So the moment you start reporting MRs post neoadjuvant, you have to write what type of cancer the patient was suffering, invasive or lobular, you have to know. Also, you have to know the ER, PR and the HER2/neu status of the patient, because this is very important. Now, why it is important? So it has been seen in research when ER positive, PR positive, HER2/neu negative, they can present as mass, non-mass. And so the complete response is less likely. Now, triple negative tumors, which are the bad tumors, ER negative, PR negative, HER2 negative, they in radiology will give you a complete response, okay? So, when you have a triple negative, your chances of reporting are more accurate. And when you don't have that, your chances of under-reporting or over-reporting is there. So, when you have a HER2/neu positive, again, targeted therapy is given, there will be a concentric shrinkage. So, your prediction of how much tumor is back there is accurate. And the moment you have ER positive, PR positive, HER2/neu plus minus, complete response less likely. So your reporting will depend on the estrogen, progesterone and the HER2/neu status. So what is the protocol over here? So in this, from the normal protocol, there's a slight change. We did 4 sequences over there. Here, the last sequence is going to be 6 minutes. Why 6 minutes? Because you have given a drug which has got an anti-angiogenic effect. So it has reduced the vascularity of the breast also. It has reduced the vascularity of the tumor also. So you're going to spread your contrast a little bit more till 6 minutes, because there would be some tumors which will actually go and enhance in the 6th minute. So you get this? So here there is a slight change in the protocol. So how are we calculating the tumor? So as I said, in our institute, we do it by diameter because we don't have a software to measure the volume. And so you can either do it by diameter or you can do it by volume. And what is the criteria? RECIST 1.1. And how are you going to measure? So you will measure one large dimension. You can do that in axial, you can do that in coronal or sagittal, whichever. But do write it down. This is the largest I have measured in this section, in sagittal, in this part. Okay? So what are the things that are going to happen? So in one breast, you can take 2 lesions, 2 target lesions per breast. Whatever rest is there, they are the non-target lesions. Okay? So per breast, 2 lesions you are going to pick up. So for the target lesion, there will be a response or there will be a partial response. Okay? So, and one more thing over here. So you have done a RECIST 1.5, 2 lesions per breast. Complete response, everyone knows. The whole tumor is gone. Nothing is enhancing. Partial response, 30% decrease in the size. Progressive. So you have taken 2 lesions, you have taken both the diameters, added up, and the diameter size is more than 20%. So you will say progressive, and at least there should be a 5 mm increase in the size, or some new lesion has come. So this is progressive. So how do you do the math? This is very important. So this is a pre-treatment over here. After 2 months, you can see 22.7. Here after the 6 months it has become 37. So what you do is, you are not, so the difference, you are going to take the size where it was the least, that is the nadir. You are not going to take the first one. 37 minus 22.7 divided by 22.7 into 100. So there is a 64.43. So this is the max you are going to do. So this is how you calculate percentage. So what happens when you say stable? So over here this is pre-treatment tumor, post-treatment tumor, no change. So this is kind of a stable disease. So you will write stable in the tumors which you have taken as the 2 points, the target lesions. So over here you can see there was a tumor, 2 months, 6 months, completely gone. So what is this? Complete response. Very good. Now what do you say about the non-target lesions? So when you use the word non-target lesions, the only difference is there's nothing as a stable disease. The line that you read over here is non-complete response and non-progressive. You are not going to use the word stable over here. So for non-target lesions, either it is progressive, or it is complete, or it is non-complete response. Got it? So this is a pre-treatment tumor, post-NACT, everything gone. So what is this? Very good. So this is a case where there is a lady who has got, now this is very important, IDC, ER negative, ER positive, PR positive, HER2 new. So this can have some non-mass enhancement. So you've done a 90-second and the 6 minutes. So 90-second you got the lesion. When you did a 6-minute, you got all non-mass enhancement also. So you got a target lesion and multiple non-target lesions also. What was the curve kinetic? It was kind of a washout. You gave chemotherapy. What happened? The lesion reduced. Now, how did the lesion reduce? You have some kind of speculated enhancement over here. You have some kind of a reduced enhancement over here. Now, what happened to the kinetics? Initially, you had the washout, and here it's just increasing. So, you see the difference? So, what will you going to tell this? So, this is the pre and this is the post. What are you going to say this? This is a non-complete, because you have a target which has given you kind of a stable. You have a non-target over there also. So what are you going to say? This is a non-complete. You're not going to use the word stable disease. Got it? So you have picked up the disease. Sometimes it can be total non-mass enhancement. So what happens? So over here you have pre-treatment non-mass enhancement, post non-mass enhancement. So what can happen over here? So here also there can be a concentric shrinkage of the non-mass enhancement. Okay, so this is a concentric non-mass, non-complete response. So here what happened, this was the pre and this was the post. The size is the same, only the tumor did not enhance after 6 months. So what are you going to write? So this is again also non-complete response. So what are you going to do if the tumor size does not change? So we are going to report this, that the tumor size is the same, but we see reduced enhancement. And this could predict a non-complete or a partial response. So over here you see the tumor is there, the size is the same, only the enhancement has reduced. So this is a kind of a non-complete response. Now, why do we have this overestimation and underestimation? So it says the sensitivity of MR depiction for residual disease is 63 to 88% and specificity is 54 to 91. So you say that around 6 to 19% is overestimated. That's good. At least you're taking out, you're not leaving the cancer. Now 7 to 28% is underestimated. This is bad because we told this is small tumor, but the surgeon has to operate a bigger margin. Now, why this overestimation? So they say that the overestimation is because of fibrosis. So whatever fibrosis or the macrophages, they are also taking up the contrast. So you're not only measuring the tumor, you're measuring the fibrosis. And this is accounting for the overestimation of the tumor. So here we had a case, but this was pre-treatment. This was post-treatment. Okay, 6 minutes we have something. So we said that this is residual tumor. Now what happened in pathology? It came out complete response. What was this? This was fibrosis which got enhanced. Okay, so this was actually pathological complete response. Now what happens in necrotic tumors? So when you give neoadjuvant, the tumor can have hemorrhage also, the tumor can become necrotic also, and you can have like some fluid also in the tumor. So you have the tumor that is not enhancing, size is the same, and you have the fluid. Now what are you going to do for these necrotic tumors? So you will write there is residual lesion over here. So you give contrast, the periphery of the tumor will either enhance or the central part will non-enhance, and this is particularly in the mucinous tumors. So here you have a case, pre-treatment you have the big tumor, post-treatment T2 you can see, then you see complete non-enhancement and then just the peripheral non-enhancing over here. So here actually there was no residual tumor, but in our reports we are going to write the tumor size is the same and it shows peripheral enhancement. So there's always a discrepancy in tumors which have necrosis or hemorrhage. So you have to keep this in mind for necrotic tumors. Now, why do we underestimate the tumors? Why is that we report big sizes and here it comes out something else? So, non-mass lesions are the lesions where most of the underestimation happens and you get a lot of false negative. So, there is complete imaging response, but you've done the surgery and you get a pathology, there is something which is there. So non-mass lesions will give you all these discrepancies. And what are the two tumors? Invasive lobular carcinoma and mixed ductal and lobular invasive carcinomas. So keep this in mind. So why I'm telling in neoadjuvant, you have to know what type of tumor, what is the hormone status, and then make your report. It's not very simple. So keep all of this in mind. So why is there kind of an underestimation in non-mass enhancement? First of all, multiple enhancing areas. You don't know where you're calculating over here. So because of multicentricity, there is loss of cell adhesion. All these factors kind of tell you or go for predicting you the accurate size of the tumor. Now, when a patient is on anti-angiogenic therapy, like the patient is on taxanes or anthracyclines, what happens is that the whole breast enhancement reduces. So you also have to know what chemotherapy the patient is reducing. So what happens is the cancer also reduces less, the breast also reduces less, and if there is a fibroadenoma, that also reduces less. So because of anti-angiogenic therapy, the lack of enhancement is there and you falsely underestimate the tumor because of the anti-angiogenic effect of the taxane. So here you have a triple negative tumor. After response, you have done the chemotherapy. Now what happened is the breast is also not enhancing, the tumor is also not enhancing. We gave it, this is a complete response. But what happened in pathology? We got there was residual tumor. So what we missed out, she was on taxane therapy. So you have to remember that. So one of our cases where 2012, you see there is no enhancement, there was tumor, this was radiation, no background enhancement. Patient was on tamoxifen, both the breast became non-enhancement. Left the tamoxifen, this breast is non-enhancing, this breast, the enhancement has come back. So it is very important to know that the patient is on taxanes or not. Now there are other methods also by which you can say the tumor has gone down or not, and one of them is ADC. So what happens is after neoadjuvant therapy, the ADC value starts increasing. So if the ADC value does not increase, you say this is kind of a non-responder. So one of our cases where the size also reduced, the ADC value also reduced, so this was kind of a partial response. Now, why are we doing all this partial response, full response? What are we getting at? We are just doing this to help the surgeon to know how much of breast is he going to take out. Because if there is a non-mass enhancement and you have 75% of the breast involved, you have to tell the surgeon, is he going for a partial or a complete mastectomy? Okay? So that is why this is one of the most important reasons why we are doing this neoadjuvant post-chemotherapy MRI. So either you will overestimate, either you will underestimate, or you will give the actual size. So now this is one of our cases, very recent cases. So you can see a lesion over here. This was hypointense. There was a lot of skin thickening. Apart from this lesion, there was one more lesion. This was kind of circumscribed. T2 fat sat, we got kind of edema over here. Diffusion restriction, we didn't get much anything. Now I've given you the post-contrast scans. So what happened here? The skin is enhancing. You got an area of non-mass enhancement. Here we got an area of non-mass enhancement. Then we got one more lesion over here which was showing homogeneous enhancement. Here you can see over here, this one. Why this is, I don't know. Wait, I'll do from here then. Okay, wait, I'll show you. So you can see here the skin is enhancing, okay? Then you get over here some non-mass enhancement. Then you get over here, this lesion is showing homogeneous enhancement. Now you can see the cursor. Why this is not moving? Now you can see, I can see over here. Why it's not coming here? No, not this one. This one, yeah. No, not this one. Here. Now can you see? Why the cursor is not there? What? Do we have a pointer over here? So I can just show you that the first image you see that the skin is enhancing. Okay. Second image you can see the skin and you can see some non-mass enhancement. Third image you see this round thing over here. It's showing homogeneous enhancement. Yeah, you can help. Okay, now, okay, fine, good, very good. So over here you can see the skin is enhancing, okay. Here you can see there is some non-mass enhancement over here. Now over here you can see this homogeneous enhancement over here. So there were two lesions. So there was a cancer and there was a fibroadenoma. Now we had to make a report. So what we wrote in our report, we did the subtraction over here. So we said there's and we measured what is the length of non-mass enhancement. So we gave that there is an area of non-mass enhancement. It measures 3.5 into 2 centimeters in the upper inner quadrant. And the other lesion was a fibroadenoma. So this is how we made our report. So first we gave the history, we told what kind of cancer, we gave the ERPR status, and we described right breast was all normal, left breast. First we described that homogeneously enhancing circumscribed, T2 hypointense lesion, measuring so much, seen in this quadrant, homogeneous enhancement. Rest of the breast shows mild background enhancement. Then what you came, the area of non-mass enhancement is measuring, this by this is seen in the upper inner quadrant. Then we wrote the associated findings. Skin and subcutaneous is thickened, the nipple is normal, chest wall is normal. We did not get any axillary lymph nodes. So this was a fibroadenoma. We gave this as a residual disease and this was a non-complete response. So we told the surgeon, listen, we feel that there is 3.5 centimeters of breast which is still involved. Okay. Now what happens in the pathology? So if you see in the pathology, the section comes 2.5 centimeters. So we overestimated. But we still told the surgeon that you don't have to take out the whole breast, you don't have to do mastectomy, just that upper inner quadrant is suffice. So when you're making your reports and you correlate it with your pathology report to see how accurate you have been in your reporting. So now last part of my lecture. What is new in breast MR? Abbreviated breast MR. Last, just hold on, just 5 minutes, okay? So what is this abbreviated protocol? So as you know, the word abbreviated means shortened. So over here, what we do is we have shortened the sequences and shortened the time. How much time? Less than 10 minutes. So what did we do? We did a T2, we did a T1, we gave the contrast, took one early and one delayed and took a thickness of 3 mm. If you want to make subtraction and MIP images do and the patient is out. We did not do diffusion, we did not do FAT-SAT, we did not do all other images. Now why are we doing this? There are so many times you have dense glandular parenchyma, females with dense glandular parenchyma. So what do you want to do with them? So you can use this abbreviated protocol and pick up a lesion. Why? Because in our country, the whole breast MRI is going to take you around 40 minutes, 12,000 rupees. You do an abbreviated MR, you do it in 10 minutes and you tell your hospital, charge 5,000 rupees. So you have given that person a reason to live. You got it? So start this in your hospital, abbreviated MRs for patients who have dense glandular lesions and pick up. So over here, look at the time. So either you do 2 phases, an early or a delayed in a post-contrast, or you just do one. You make your own protocol. Whatever you feel, you do it. So whom do you advise? Ladies with dense breast. So over here, look at the time. The time is less than 5 minutes. Now, dense breast, we did a T1 pre-contrast, post-contrast, no, nothing is enhancing. We assured her. Subtraction images that there is no lesion, you come back after 1 year and we will again do an abbreviated MR. Over here, again we have done over here, T1, T2, we have picked up a lesion, enhancing lesion. So we have picked up a lesion. Now you have picked up a lesion, now what are you going to do with that lesion? So the American College of Radiology says that the same thing, if you pick up a focus, That is T2 hyperintense. That's a cyst, that's benign. Don't do anything. You pick up a focus which has got a rim enhancement. You do a biopsy, or a focus which has got irregular margins, heterogeneous enhancement. You do a biopsy. You pick up a mass lesion, okay? And it is circumscribed, homogeneous, T2 hyperintense. Don't do anything, just leave it. Heterogeneous enhancement, you do a biopsy. So I told you all the T2 lesions, cyst, fibroadenoma, proteinaceous, all that don't do. The moment something deviates from that, you do a biopsy. And when you have a non-mass enhancement, if it is linear or segmental, you will do a biopsy. Clumped or clustered, you will do a biopsy. Only when it has got internal enhancement, homogeneous enhancement, and fibrocystic, you want to follow up. So most of the non-enhancing masses, you will do a biopsy. So with this, I come to an end of my lecture. Thank you very much.
And sorry for the guests for the alignment. I guess you were more comfortable watching from there. So I would like to request all our respected chairperson and panel of experts to come on stage, please. Sir, thoughts and insights on the topics addressed by our esteemed speaker today.
Rashmi, for his excellent lectures and share her experience with us. I think her lectures deepen our learning process, and by that way the patient will help from our learning. And all I say, are you enjoyed the session? Okay, everyone enjoyed the session. Thank you so much.
Dr. Kamrujaman is here. I'm very happy to see you. I have noted some points. Dr. Rashmi has not left any point. Am I correct? I am correct. Has not left any point. She has started with technique, post contrast, not to do within after 14 days of period. Dark, if it is dark, then you think about it is a suspicious lesion. T2 bright, you think about benign. Focus, she said about masses, shape, margin, circumscribed, and enhancement pattern is very, very important. Dark septations, you can think about fibroid. Non-mass enhancement. Enhancement pattern is very important, I have said, and dynamic enhancement is also very, very important. So, finally, she has shown 10 cases. All are very, very interesting. Very, very interesting, I should say. Then, she showed us some post-chemo. Very difficult. I'm still. Let me tell you that first mammography machine in our country came around 1993. X-ray mammography machine came in 1993. One in CMH Dhaka, and in 1994 in Popular Diagnostic Center, where Sharmi is working now. 2 mammography machine. Then mammogram, MR mammogram came in 1998. In CMH Dhaka, there is only one breast coil, because breast coil is very, very expensive. And will you believe that in 10 years, I did only 2 mammogram, MR mammogram. And that is why the diagnostic center, they are not buying mammography coil, because patients are very less.
They start abbreviated.
But nowadays, very, very important with treatment, chemo, whether the size is reducing or not, responding or not. So mammography has come up. So everybody will have to, all radiologists will have to know the mammogram. They will have to know they will have to understand the mammogram and the read MR mammogram, and the surgeons will wait for this. But the one thing is that histopathology, the core biopsy, nobody superseded this core biopsy. Whatever you do, PET CT or MR mammogram, you will have to do biopsy. Finally, I want to thank Rashmi. We have been talking for last 2 days that what will be her presentation. I said that most of the residents and the juniors want to learn from you. So we prepared the cases like this, and she has followed my suggestion. And finally, uh, the, the presentation was very, very good, and I thank you very much from my side. Thank you very much.
I'd like to thanks from our part of radiologists, sir already left, Professor Kamruzzaman sir and BSRI for arranging such a wonderful session. Thank you.
Actually, I feel like standing up and speak because otherwise I cannot see the audiences. Thank you, Dr. Rashmi Chand, for an excellent presentation. Actually, previously, say a few years back, we have been thinking that mammography is a complementary study to, MR mammography is complementary to breast mammography and ultrasound to this. But nowadays, the importance of MR mammography has become so important because very small lesions which are likely to miss in the ultrasonogram and also in mammography, X-ray mammography. But the MR mammography picks up all those tiny small lesions also, number one. And number two is very important that in dense breast especially, it is very difficult to understand by conventional X-ray mammography and ultrasonography. And MRI is the choice where we can find out these lesions. And special thanks for letting us about the brief mammography, because personally I did not have that idea then how to do that brief mammography. So, and thanks to all the audiences for your time, and with so much of enthusiasm, you have come here to listen to Dr. Rashmi Chand, who is, we know that she is a very learned, both in her practical hands, everyday life. I had a talk with her that she is doing all kinds of breast-related examinations and biopsies and everything. So thank you very much, you and everyone, for arranging such a nice program. Thank you.
I have two questions actually. My first question is there any role of kinetic curve in case for axillary lymph nodes, suspicious axillary lymph nodes?
Hello. So let me tell you all axillary lymph nodes,
Yeah.
basically. So for the lymph nodes, what matters is the size and the cortical thickness. So, and if suspicious,
But
you do
in
biopsy.
MRI, we don't.
No,
have
we
to-
don't talk about the kinetics of nodes in MR because all nodes have a rapid
yeah,
version and
assumption,
washout. So type 3 curves.
And role of
Yes, there is. You can do so, but sometimes, we get some very bizarre curves.
Yeah.
So that is
I
there.
face.
Every time it does not perfectly fit into 1, 2,
Yeah.
3. So sometimes it acts. So what I want to tell you over here is never diagnose a lesion just on the basis of enhancement or the kinetics. Always correlate it with the morphology.
yeah.
That is very important. And you take the morphology, the kinetics, the enhancement, and then come to a MRI or the BIRADS. So for the same thing, I'll say for the residual disease also, look at the ERPR, look at the type of breast cancer, this thing, everything, and then write it. So just don't do it on kinetics.
Sometimes in pre-treatment, tumor shows type 3 curves, but
Yes.
post-treatment shows type 2 or
Yes,
something.
yes,
like
definitely
that.
you can get that. Definitely you can get that. Do a kinetic curve, but just don't depend on the kinetic curve.
Okay.
Make an overall assessment. That's what I'm going to tell you.
Okay.
Okay?
Thank you so much.
My MR mammogram guy, but after that I'm practicing general radiology, so I have to sometimes I have to do this. I have a very silly question possibly. If it is diagnosed case, is there any importance of doing kinetic curve or giving kinetic curve in our report? Because sometimes case come with diagnosed, right, after biopsy.
Indication. You're not doing the MR to diagnose the lesion.
Yes,
So
yes.
what I want to tell you is, suppose if there's a lesion that is diagnosed and still the surgeon wants that, please do it.
Yeah.
So you describe the lesion and you write, this is a known case. So it's already a BIRAD 6. So you don't have to worry about the curve or anything.
What I want to say that in our country, we are getting many cases after diagnosis to find out the other cases or surgical planning, possibly. First, I said that I'm not MR
No, it's
mammogram
okay.
person.
Fine, absolutely
So whether sometimes I get confused. Somebody here practicing with kinetic curve and some are not.
Yes.
So my question to you is specific. Is that important? So it is easier avoiding giving kinetic curve, right?
What I'm going to tell you is just don't write that the kinetic curve is type 1 or 2. I taught you there are 2 phases.
Yes.
So write that the lesion is showing slow enhancement in the first 2 minutes, okay? Or showing fast enhancement. Describe it. Why? This will tell you what is the nature of the lesion. Too bad, very bad, whatever it is. And then you write, post this, the enhancement is stable or it is progressing and this, and then you derive what is coming out of these 2. So, and then you put it a type 1, and if you really don't know it is a type 1 or type 3, safely write type 2, and you just get out of it.
Okay, thank you very much.
Thank you. No, I usually put it in the delayed phase,
Delayed
like the
phase.
last one.
Okay.
The last one, you put the ROI and you draw this thing. And once you've given the ROI, so the ROI enhancement, the time to peak, everything the computer only makes the
Yeah.
chart. You don't have to do anything about that.
No, I know. So you put the ROI in delayed phase.
Yeah, but then here also there is a caveat, okay? There is something known as ultra-fast MRI.
Yeah.
So we have that sequence also, where the first sequence starts from 25 seconds only. Okay, there are some tumors which will start enhancing from 25 seconds also. So what happens is, then what I do is, then I see the phase in which it's showing the maximum enhancement, and then I start doing the ROIs.
Okay.
So that is why, you have to use, like, what are you looking at?
Okay, thank you.
Words regarding breast MRS.
Sure.
Because in 2015, I attended in RSNA and they showed a lecture, showed that there is a phosphocholine is very specific for ductal carcinoma in situ.
Okay,
So would you
spectroscopy.
please tell us few words regarding breast MRS?
No,
Where
I
we
don't
can
do,
use this?
I don't use breast spectroscopy because it's not a part of BIRADS also. We have tried, but we got very inconclusive things, so we don't practice MRS.
Our Jangir sir was with me in that
Okay.
RSNA.
Okay, okay.
We attended the same lectures
Okay,
and
okay,
they showed
okay.
that. But
Yeah, yes,
in the
they-
long period of time,
Okay,
2015.
Okay,
So
so
they
no,
are
I
sure
don't
perhaps.
have much experience on MR spectroscopy. Thank you.
Okay, thank you.
I face some problems and I like to share
Sure,
my
sure.
problems with you with the hope of some solutions.
Thank you. I will try my level best.
Thank you. My first question, in my protocol, I set my exclusion criteria as a history of recent surgery.
Okay.
But I search on a lot, some articles, but I don't get any guidelines which is the time, what is meant by recent surgery. I mean, what is the time duration?
Okay, so you want me to ask that not more than that, because what will happen, inflammation will also enhance and that will look like a non-mass enhancement. So till 6 weeks, don't do anything. Post 6 weeks, you are safe to go ahead.
Okay, thank you. Another question. In case of post-surgery MRI, we face some problem in differentiating between scar tissue and recurrence. Sometimes both of them enhance.
So what
and we
happens-
know the scar tissue can enhance within first 12 months.
Yes.
When we should differentiate.
See,
between
if you
these
want
two.
to differentiate a scar tissue, and this is, as you know, that fibrosis enhances in the delayed sections. That's why I tell you now, the 6 minute question, this thing I said. So first set your protocol where you're just not scanning till 4 minutes. Do the dynamic, stretch it up till 6 minutes, because fibrosis has got a delayed enhancement, okay? And there are very few tumors who will enhance. So tumors will enhance early till 4 minutes, but what enhances till the late, the one in the 6 minutes, that is fibrosis. And still if you have an issue, you take the patient in ultrasound, you put a Doppler, and you will see no Doppler over there, and you will safely say this is fibrosis. So this is how we sometimes, you have to make use of all the modalities. So you have that, you take the patient into ultrasound, put a Doppler, tumor will have vascularity, fibrosis will have no vascularity. So you confirm, duality, you do confirm it. You got it? Caveat over here. So if you have to know what kind of diffusion restriction, get a cystic this thing over there. So I'm just telling you, don't depend on one sequence, okay? So if you have a cyst which is completely showing diffusion restriction, it goes for abscess, okay? If you have a lesion where only the wall or a nodule or a part is showing the diffusion restriction, that goes in favor of cancer. Got it? But there can be tumors which will show complete diffusion restriction. I'm not telling that, it can happen, but there will be very other characteristics like it will be deeply hypointense, it will have irregular margins. So you take into consideration of everything. So don't just stick to diffusion restriction. Got it?
Can benign lymph node show diffusion restriction? Axillary lymph node?
It does. There's a lot of research. Now, when do you say diffusion restriction? You start taking the ADC values. So this is the ADC value. This is the cutoff for benignity. There is a factor or a cutoff for malignant. Then you start doing, that kind of thesis thing. But what safely for me would be malignant is the size and the cortical thickness. And sometimes if you have nodes which are round, the moment and let the surgeon in the OT do the radionuclide scan to pick up and decide what he wants to go ahead. But you be sure of what you are doing. Got it?
Yeah. Is subtraction images very much as in
Computer is doing it. So why I go for subtraction is because the breast is also enhancing, the tumor is also enhancing, and sometimes they merge. You get it? And so it's very difficult. So when you do subtraction, sometimes you just pick up a lesion in subtraction sequence only. So I feel this is must. So please do subtraction.
In the MR console, or you ask for a stereotactic biopsy, or how do you approach it?
So, ma'am, whenever you have a focus that is enhanced, so either you do it
So
or
if you do not have the facility, then what do you do?
it actually is a waste.
Like, I don't know whether we have the facility of MR
So
biopsy
that's
in
why I
Bangladesh.
said that for focus, retrospectively, if you try to pick it on ultrasound, I don't think so that is possible. So, if you do an MR, you pick up something and you can't biopsy, it's actually a waste. So you should have a center for attached
my
for...
question to Jahangir sir, my mentor, please, can you just tell us whether the MR...
What Dr. Rashmi said, if I can see, I think it will be visible in ultrasound also. There are now, the ultrasound machine, she does non-vascular interventions, I know. If it is not dense breast, not very much, but I think it will be visible. But in our country so far, the biopsy in MR, different types of needle, different types of instrument is required. So till now, I know that Rupa is not also having this. We are not having this because we are doing
So
by
sir,
ultrasound.
I think we need to bring this. Sir, thank you.
Maybe Professor Kanu.
Gradually, the hospital will think we need that one actually. Yeah, definitely. In oncology, we need a lot of instruments, especially MR guided biopsy for special needles and other things.
So what happened is that, so how did I increase the numbers? I started abbreviated. The moment I started abbreviated, 5,000 rupees I was doing MR. So every day we are having 2 abbreviated. I started picking up and then I started the biopsies. Are you getting it? So you justify it, go ulta.
She is right, because you will have to get the return. What we are doing, the abbreviated MR, first MR, or ABMR, it is known for last few years, but it has already started. We are doing 3-sequence MRI for brain to cut short the price and cut short the time. We are doing it, 3-sequence MRI for anything. To cut short the price and cut short the time to increase the number of patients. So I think it will come in future. If we can do more biopsies, the management will think about buying the needles and other things. Those who are not paramagnetic, those will be used in the MR suit. Yeah. Thank you.
One thing, why we are actually, we treat breast cancer patients, we need to do the breast MRI. So our radiologists, even the oncologists should know actually what's the benefit of the breast MRI. Rupa is doing only in one center, but so we need a lot of centers in the country. That's why we made this program. Radiologists should say we need a breast MRI especially, and the hospital will think definitely.
You know that we are doing MR mammogram since long, but few centers are doing. The number of patients are less, but it will definitely increase because the requirement is increasing day by day. Thank you.
I used to say, So whenever, see, I'll tell you, whenever we get something like a unknown nipple, like a reddish discharge or something coming, so what we do is like we do the MR, and the nipple is not very well seen in the MR. I'll be very honest to you. So what we are actually, so if you are suspecting something within the nipple, so the first thing I'll tell you is go for the biopsy, the USG guided biopsy for Paget's disease or whatever it is. Now what we are looking in the MR is a duct which is enhancing and is causing the bleeding. So in MR, you're actually going to pick up that ductal enhancement. You're not going to pick up a disease of the nipple. Got it? And that is what you should biopsy. But if you're suspecting Paget's, areolar, all this, I would prefer the ultrasound is a better modality than MRI. And so the sequence in which you will see nipple retraction very beautifully is the sagittal or the coronal. Ma'am, in axial, what happens? That is very dark area. So that's why I say go back to this thing. If you are seeing the enhancement is going and the nipple is puckered and coming out, do mention it. If you are not, if suppose you don't see it, just write that nipple cannot be commented on. What you see, you write. Don't overshoot or don't undershoot, right? I cannot see it. I don't know about it. You can always see that in ultrasound. So you make use of all the modalities. This is what I want to say.
But I really like the
I hope that it was very wonderful and insights and valuable remarks. Your contributions have undoubtedly enriched our understanding of these critical topics and will inspire further advancements in breast cancer management. I'd also like to thank all the delegates, both from home and abroad, for your active participation and engagement. Let us continue to collaborate, learn, and innovate in our shared mission to combat breast cancer. Thank you, and I wish you all a productive and inspiring conference ahead. A little announcement, so we have also the arrangement for dinner after this session. Thank you so much, everyone. Dinner will be served in Chitra.